So good afternoon. We like to start because the limited time we have. We should have 115 participants, but they are not all here, I think. Welcome to the 18th Physiotherapy Forum of the ICS. I have nothing to disclose. This is the program. And please complete the in-app evaluation in this session before leaving. That is very important for the physiotherapy committee. So just open the app and select the program by day, locate the PT forum, and scroll to find the evaluation button and complete the survey, please. The handout is available via the ICS app, the USB stick, and the website, of course. Please, if you have any questions, do that at the end of each presentation. Go to the microphone and say your name and where you're from. And please silence all mobile phones. And after that, at the end, you can take a drink. There is a drinks reception. I'd like to introduce the first speaker. That's Julia Herbert. Can we have the presentation of Julia Herbert, please? Julia has specialized in continence and women's health for over 30 years. She currently works full-time in her own private practice, and she is currently a clinical tutor and honorary lecturer of the University of Bradford, and an approved tutor, for pelvic obstetric, gynecological, and physiotherapy. And Julia has lectured extensively in both the UK and internationally, which we know, and has made a number of appearances in the media promoting continence care. Success, and thank you for being here.
Yeah? Thank you. Oh, round of applause. That's before I start. So thank you to the Physiotherapy Committee. It's a real honour and pleasure to come and talk to my fellow physiotherapists, although there are some other people in the room, and I'm going to tell you more about that later, because I have a little survey results I'm going to share with you. So we're not quite all physiotherapists in the room. I was asked if I would talk about electrical stimulation, which is a huge topic. It's a big hobby of mine. I have a passion for it. And it's quite hard to decide which bit of it to talk about for 20 minutes. So I thought and took rather longer than Petra would have liked me to take thinking about it, because I didn't get back to her quite as quickly as I should have done. And I decided that I would focus in on specific area and look at contraindications and precautions about the types of stim that we might use as physiotherapists. These are my disclosures, and one of those is relevant to this presentation, particularly because I will mention a product that is related to my role in FAMIDA. So I want to look at what we use in physiotherapy, so the range of equipment and types of stim. There are some slightly on the edge of what physios do, types of stimulation that I haven't mentioned in my presentation, but particularly for contraindications and precautions, I have specifically focused on using it vaginally or anally across a range of conditions. So we're going to look at types, look at when we wouldn't use it, and look at when we would be careful with using it. So most of us are probably fairly familiar, if we do use electrical stimulation, with using it with a probe in the vagina or using it anally in men or women or in both. Some of us may use skin electrodes on the perineum, or there are new pieces of equipment, which I'm going to mention briefly, where there are surface electrodes that are applied around the buttocks and the hips to crossfire into the pelvic floor, or a pad that's placed on the perineum between the legs to try and crossfire. Some of us may have seen or looked at the electromagnetic chair. We can use percutaneous tibial nerve stimulation, or when I first heard of that, it was called Stoller afferent nerve stimulation. The names change, but the process is the same. And there is also a procedure for using transcutaneous electrical nerve stimulation, particularly around inhibiting bladder. So, thinking about evidence, I didn't want this to become a presentation just all about the evidence. So I had a quick look. Being from the UK, the main body that we reference to is the NICE. And so most of the practice that we will carry out in the UK will be guided by what they say. And based on the evidence that's at the level that they will consider, we get these statements. Do not routinely use electrical stimulation in the treatment of women with overactive bladder. Do not routinely use electrical stimulation in combination with pelvic floor muscle training. Electrical stimulation and/or biofeedback should be considered for women who cannot actively contract pelvic floor muscles to aid motivation and adherence to therapy. So if we take that, we are taking quite a limited view, but it's based on the level of evidence of randomised controlled trials. And if anybody was at the welcome meeting opening of the conference, we heard this morning very eloquently expressed that that's only one part of the picture. So what we get from our RCTs is actually giving us quite specific data, but there's another side about individual patients, about what their need is, and that as clinicians we need to actually apply that knowledge and work out how to deliver things specifically for patients. What's new in electrical stimulation? Well, until probably 5 or 6 years ago, not very much had changed from when I first started working in women's health, which I now started telling people I was only 6 when I started, because I realise I've clocked up 34 years of working in pelvic health, which seems impossible, but it's true. And not much has changed for a long time. We had small handheld units, we had wires, we have vaginal probes, but recently things are starting to move and innovation is starting to come into this area of electrical stimulation. And I feel it's been a bit of a Cinderella side to some of the treatments that we offer, and maybe it has got a little bit more to offer to patients. So the product that I've had some involvement in is the Pelviva device, which is a vaginal application of neuromuscular electrical stimulation. Has got some evidence behind it. We have a randomised controlled trial which showed statistical significance when compared with women just doing pelvic floor exercises on their own, not supervised exercises. So a different approach to stimulation, no wires, you don't have to connect to a machine, you can walk around, you can be free. So delivering a therapy to women without some of the hindrances that we've seen with other bits of equipment. And then for women who actually can't tolerate a device in the vagina, but we want to treat them for stress incontinence, there's the Innovo device, Vital, which some of you may have heard about. And I'm not sure whether they're here, but I saw them at a previous ICS conference, the Elitone device, and I've just seen some interest on the media about they're launching their product. They have got FDA clearance for it. Whether it's come to Europe yet, I'm not sure, and I couldn't find any literature supporting it. There is one clinical trial registered on clinicaltrials.gov, but it hasn't started recruiting yet. Just looking around the evidence supporting the types of stimulation that I was going to ask questions about when I asked you to give me some information about what you do. The other paper that I found was a recent meta-analysis looking at magnetic stimulation. Magnetic stimulation's been with us for quite a long time, but the evidence base has never been particularly strong. So my knowledge of colleagues around in the UK, until recently it hasn't been very widely used, but it is having a little bit of an upsurge in the UK. And there are some centres, mainly in the private sector, because it's quite expensive. And this meta-analysis is suggesting that there is some evidence of efficacy, but I think we need a lot more to support it. And certainly if you look at the way NICE measure things, they look at a cost and effectiveness balance. It's going to struggle because it is quite expensive. So then we get to the thing that I thought I'd focus on in this talk, which is contraindications and precautions. And really what got me interested in this is that the Pelvic Obstetric and Gynecological Physiotherapy Group, which we shorten to POGP because it's such a mouthful, but POGP started to write some good practice guidelines on using neuromuscular electrical stimulation. But we've really struggled because there's not much evidence out there about when you should use it, when you shouldn't use it, who you can use it with, what equipment you use and when you use it. And Doreen's following me about electrical stimulation, the next speaker, and I know she's going to talk about parameters and what evidence she's been able to find about the types of way we use stim. So I thought I'd focus on what we do. So there's not much evidence in the literature that talks about this. So I thought, well, we've got over 100 physios coming to a physio meeting in an international conference. I'll do an online survey. So thank you very much to those of you that answered my little online survey. I got 63 responses, which I was pretty chuffed about. That's 60%. And in research terms, people said, that's pretty good. And it was a bit hard to try and ask because each country has a different way of describing what you are. So apologies if I missed anybody out. I did put another so you could write if you didn't fit any of the categories. And it's been interesting to see what people have come up with. We have quite a range, but mainly we're specialist physios. And thank you to the urologist that completed the survey because I wasn't expecting. I was just thinking we were going to get physios back. So that's quite good. And where are we all from? Well, just look at that range of countries. Isn't that quite impressive? Well done, the Dutch, the Netherlands. They win the prize. Followed by the Australians, which is a long way for them to come to Gothenburg, and the Norwegians and the Finland are there as well. But it's really good. We're a really international meeting. So what I was going to ask about was then, well, what makes us use STIM? What stops us from using STIM? So I actually asked, first of all, do you use STIM in your practice? So not everybody does. The response was 71%. Generally, we treat both men and women, most of us. Some only treat women. And some actually, one person actually answered, treat both genders and transgender. So that's an interesting conversation as well, because certainly I've no experience of treating transgender people. When we come to look at the type of stimulation used, it really made me reflect on some of the slides I've just given you that I'd already put together before I got these results back. Because the body-worn shorts, nobody answered that they were using that. The magnetic stimulation, nobody said they were using that. And very few of us answered that they were using transcutaneous stimulation or tibial stimulation or TENS. So you can see the figures, and that the majority, the blue line, most of us were actually using vaginal and anal stimulation. Okay. The questions then went on to say if you're using vaginal or anal stimulation, then we'll ask about what's contraindicated. And what I've tried to do in these slides, because we don't have a lot of time, is actually cluster some of the categories together. So thinking about pregnancy and childbirth, I asked, would you use stimulation in pregnancy? What about in the first 6 weeks after pregnancy, after delivery? And what about in the next 6 to 12 weeks? And you can see I've colour-coded it using the English traffic light system. So red is stop, don't do it. Amber is I'd think about it carefully, but I might still proceed with certain patients. And green is yes, I would definitely use it. As we go further into the questions, some of the categories I've colour-coded differently. It might be that we would discuss it with a multidisciplinary team, or I don't know, I'm unsure, I really have no guidance on it. So we can see that most of us would not use it in pregnancy, but some would with caution. So that's an interesting discussion. And I apologise now because I'm going to throw up lots of questions and I don't have the answers. But I think what this might mean is that we need to go and find the answers. So maybe this is something for the physiotherapy committee to start to look at. Slightly more would start to use it in the first 6 weeks. and a lot of us would start to use it after 6 weeks, between 6 and 12 weeks, but some still wouldn't use it then, and some would be very careful. And perhaps that might come out in Doreen's. I've not seen your presentation, Doreen, so I don't know, but maybe we'll see that different parameters can be used at different stages. Certainly that's something I've seen before. When we look at pelvic surgery, in the pelvic surgery in the last 6 weeks, quite a lot of us, the majority of us, actually said we wouldn't use it, and the rest would be quite careful. And the purple on this one, there was a few answers that depended on the type of surgery, so it depends on where the surgery is. So obviously these questions are a little bit difficult to structure because it was quite a broad question. So the next question was, what about pacemakers? Which is quite interesting, because I've been brought up in the UK thinking about STIM that it was a complete no-no to use it with a cardiac pacemaker. But you can see that there are people who've answered they'd use it with caution, and there is somebody who answered that they definitely use it with a cardiac pacemaker. So we've got to think about, what's the evidence? Is it safe? Are we actually not using it with patients because we think it's a contraindication and actually withholding treatment? Dare I say it, treatment that could benefit somebody. So some of these really do start to throw up some challenging questions about, are we just doing this because somebody told us to do it this way, or do we really have strong evidence that it's safe or it's unsafe? Next one was pelvic cancer. So in the first 6 weeks post-surgery, quite a lot of people would not use stimulation, and some would caution. Some just didn't know the answer to that. We've got discuss with the MDT. But certainly in the UK, you can discuss with the MDT, but if you go ahead with a treatment, you're responsible as the physiotherapist if you're delivering the treatment. So you actually have to have the knowledge and make that decision yourself. Once we go to 6 to 12 weeks post-surgery, we've got a mixture of contraindications and precautions again, and we get a little bit where people are starting to use it. And then we get more people who will use it once treatment's completed. So hopefully the colour coding's giving you a bit of a sense of when things change. But clearly we don't have the answers to this, do we? We've got a real mixed bag of responses. And as my questions go on, the colours get more varied. So if we look at other conditions like low blood pressure and high blood pressure that you will see sometimes on precautions or contraindications in manufacturer's equipment instructions, then people are using it in those cases. Some of us are going to be quite cautious and other people really just go ahead and use it. Epilepsy is an interesting one because there's very little evidence that we have around epilepsy. Damage to the tissues tends to stop us initially, but there were comments about depends on what's damaged and where it is, so we would assess the patient. Infections and urinary tract infections generally is, the majority of us are saying it's a contraindication. Thinking about using it with other devices that may be in the vagina, so with the prolapse pessary, and I'm thinking like the ring pessary. This has been quite a discussion that I've been having with people around the product that I'm involved in, because we have had an issue with a patient who tried to use the product, but she had a ring pessary in and it caused problems in using it. So we've got quite a spread across the board, and quite a lot of people said, take the pessary out. So if you're in an area where you have self-managed pessaries, then that's the solution. The coil, so intrauterine devices, whether they're copper coils, whether they're Mirena coils or any other kind of coil, we get to metal in the field. So the coil starts to jump over into the metal in the field, and there's a real mixture. Do we do vaginal anal stim with metal there, or do we not do it? So that's a biggie for me. We don't know. There's a real spread across what's happening. So where did this get me to? Well, as a clinician, we have to respect what the manufacturers say, because that's where the safety data comes from. If you have a medical device, certainly in the European community, but the same goes if it's an American cleared FDA device, and they often will follow with Canada and other countries, then it has to be shown it'll have a risk management file, it'll have a risk assessment. So the manufacturer's instructions, if they say you shouldn't use this device with pelvic cancer, then you shouldn't use that device. Even if we come up with something different, what we'll have to do is come up with the evidence to change what the manufacturers then say for their device. There's a real lack of consensus, isn't there? The traffic lights are all over the place. Should it be contraindication? Should it be precaution? Is it an individual patient assessment? But I would like to see that we can have a little bit more data to steer our treatment. As I say, perhaps we are holding back. We're making a decision as a therapist that I won't offer stimulation at all to somebody who might really benefit from it, but we're doing it because we've learned somewhere in the past that that's a contraindication, or the manufacturer said that because they haven't anywhere to go and find the evidence. So I hope we can use this as a springboard to actually generate some evidence. Thank you.